Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting and we're coming to you from Meanjin, the land on which this podcast is being recorded. In this three-part mini-series, we're talking about in utero surgery with Dr. Glenn Gardner, a maternal fetal medicine specialist and director of the Mater Centre for Maternal Fetal Medicine at Mater Mothers Hospitals. This episode is about twin-to-twin transfusion syndrome, a condition that affects about 1 in 10 identical twins that share a single placenta.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Hi Glenn, welcome to sMater.
Thanks for having me.
Glenn, first of all, what is twin-to-twin transfusion syndrome?
So twin-to-twin transfusion syndrome, which is quite a mouthful, or TTTS as we like to call it, is a condition that only affects twins that share a placenta. And the underlying problem is that they have blood vessels that connect between the umbilical cords, where one baby is pumping blood into the other baby. And those connections are unbalanced. So one baby has a lot more urine output, gets excess fluid. The other baby has less urine output and has less fluid. And that really describes the condition as it presents to us clinically. It's associated with a high risk of the baby's dying if it's not treated.
Okay, how is twin-to-twin transfusion syndrome diagnosed? And what are the signs that primary carers should keep an eye out for?
So twin-to-twin transfusion syndrome, and I might just shorten that to TTTS because it's
idea.
a bit easier. So TTTS is usually diagnosed by ultrasound, but actually women may present before the ultrasound with symptoms. And the most common symptom would be that their tummy's getting big rapidly over a short period of time. Well, first of all, they've got twins. Now, it'd be nice to think that all women know they have twins at an early stage in pregnancy, but that's, across, rural and remote regions, that's not always the case. So anyone who presents with positive pregnancy tests and their tummy's getting big, one of the first things I'd want to know is, do they have twins? And could this be TTTS? And so that excess fluid is one of the key symptoms.
And how are you testing or screening for the excess fluid?
So if we go back a step, if we know someone has twins from an early stage, a lot of people have an early dating scan and we diagnose twins, and the type of twins is really important. So the two commonest groups of twins that we like to categorize are monochorionic twins that share a placenta but are in separate sacs, and dichorionic twins that have two separate placentas and two separate sacs. Now, dichorionic twins behave generally like singletons. They're at increased risk of preterm birth. But monochorionic twins have all these other complications that are possible, not in every case, but they're much higher risk because they share a placenta. And so from an early stage, if we know someone has monochorionic twins, they should have fortnightly scans. And those 2 weekly scans can give us an early heads up that one of those complications of a shared placenta is actually happening. And then they would get referred to us.
Which twin is TTTS more dangerous for, the donor twin or the recipient twin, and why?
So it's a very good question. It could be either. It could be both or it could be either. Generally, TTTS can sometimes get mixed up with twins of a different size, and that's a different problem. So twins that share a placenta don't always share the placenta equally. So one might be bigger or normal size, the other one might be really small because it's not evenly shared. Now, that's not TTTS, and we get a lot of referrals because of the size difference saying, could this be TTTS? It's actually about a placental share. So in those cases, there isn't really a donor and a recipient. But if we go back to the scenario of TTTS, where a recipient receiving blood from the donor is pouring out much more urine and has a lot more fluid, and the other one has less fluid, they're both at risk. So the recipient's at risk of heart failure from overload, having too much fluid, and the donor's at risk from having too little fluid and renal kind of impairment.
If one of the twins does die, what is the impact for the surviving twin?
That's really important because they share a placenta, and invariably these twins will have connections blood vessel connections on the surface of the placenta. If one twin dies, then the blood pressure in that twin drops dramatically, and blood from the surviving twin can flow unfettered across the placenta to the point where that twin that might have been able to survive could either die also or suffer lack of oxygen to the brain and then have permanent brain injury. That occurs about 30% of the time if one twin dies. So that's death or disability. In about 2/3, 70%, the surviving twin will be okay. And we can do some tests to find out if the surviving twin is going to fare okay.
Can TTTS also occur in multiple pregnancies like triplets and quadruplets?
Yeah, so it does relate to whether there's a shared placenta. Now, we looked after triplets where all three fetuses share one placenta, and there can be this three-way sharing of blood vessels on the surface of the placenta, and they can get triplet to triplet transfusion syndrome. It's very rare. Most triplets that we see will have a monochronic pair plus a singleton as the set. The singleton is not connected, but the other two sharing a placenta can get twin-to-twin transfusion syndrome.
And it's important, I guess, at this point to talk about the treatment options then for TTTS.
So over the years, the treatment options were largely driven by the excess fluid in the recipient sac to reduce that, because then you're going to reduce the risk of ruptured membranes and preterm birth. Later on, an important discovery in the US was that if you introduced an instrument that could laser the blood vessels between the twins on the surface of the placenta, you could really stop the underlying cause of the condition. And we adopted that approach back in 2002. We did the first laser in Australia. And since then, we've been the busiest unit in the country. We do about 20 to 24 lasers a year for TTTS, and our counterparts interstate would do somewhere between 8 to 15, just to give you an example of our I guess exposure to the condition. And they're not always straightforward. Sometimes they're very straightforward, where we would expect survival to be in the order of 3/4 of babies surviving after the laser. If you compare that, if you don't treat, the rate of loss is somewhere in the order of 80 to 90% of babies won't survive without treatment. So if you can convert that to overall 75% survival, it's pretty dramatic, like in terms of the effect of laser surgery.
You talked about some of the complications. Can you explain a little bit more?
Unfortunately, we can't get away without some risk when we put an instrument in through the wall of the uterus and operate in utero on the placenta. The biggest risks are ruptured membranes and preterm birth. On average, we would get 10 weeks after a laser before delivery. And when I say on average, some patients will go near to term and others will go even earlier. So that's always discussed very carefully with parents before we undertake the procedure. But when you balance like what the alternative is of not treating, it's a no-brainer about kind of what the approach should be.
Can you also step us through that laser surgery and the time, what happens during that procedure?
So once we've made the diagnosis and we've done the counselling and parents have chosen to proceed, we would do the procedure, the laser surgery, in theatre. But they don't have a general anaesthetic. They just have some sedation. And so they're awake and they can actually even watch the procedure if they want to. And they're comfortable. Local anaesthetic on the skin. It's a single 3.5, 3.8 millimetre little instrument that goes in through the wall of the uterus. And through that, we can do everything. I can visualize the placenta that's projected onto a big screen, and I can introduce a laser fiber and laser vessels that I carefully select that are the vessels that are causing the problem. I don't want to laser any vessel because I want to leave, obviously, the rest of the vessels for the babies to grow and thrive on after the laser.
There's so much interest in the work that you're doing. So we've asked a number of GPs to submit some specific questions to you. Okay. Glenn, can you please explain the difference between DCDA, MCDA and MCMA twins and how that influences the risk of twin-to-twin transfusion syndrome? Is monitoring different depending on the type of multiple pregnancy?
Yeah, great question. And yes, it is very different. So we'll start with DCDA twins, which accounts for 2/3 of twin pregnancies, the most common type. And a lot of people will think DCDA twins are the non-identical twins, and mostly they are, but there can sometimes be identical twins amongst those dicurrent DCDA twins. The important thing is they don't share a placenta. So they're not really going to harm each other in utero. And hence, we don't need the same level of surveillance. So it's more about growth and well-being every 4 to 6 weeks generally for DCDA twins. Monochorionic or MCDA twins, where they share a placenta, are the ones at risk of twin-to-twin transfusion syndrome. Although they share a placenta, they actually still have their own sac. They still have and that's the diamniotic bit. They're monochorionic, but diamniotic. And that's the bit that the monochorionic bit is the bit that says they have one placenta. Now, monochorionic, monoamniotic is different again and much rarer. That's where both twins are in the same sac and share the same placenta. Interestingly, whilst you might say, well, they also are at risk of twin-to-twin transfusion syndrome, they hardly ever get it. And that's why we believe that's because their cord insertions into that placenta are very close together, and they have a lot of connections that are balanced. So they tend to sort it out. They're at risk of cord entanglement, though, which is a different problem. The others are not at risk of that. And we monitor them very carefully because if they get entangled, they can die suddenly without our ability to intervene. So we monitor them at least fortnightly, and then we tend to deliver them early because we won't tolerate when they could survive the tragic loss due to cord entanglement.
Another question from one of our GPs. When a patient is referred to MFM, what is the process like? If my patient is coming to MFM for the first time, for example, after an abnormality is found on a scan in the community, what can she expect to happen? Who will she see on the day? And will she have counselling? And are those results communicated back to me and the rest of the team? Lots in there.
Yeah, it's a great question because really some people don't know what we do, and we're a multidisciplinary service. And the point of that is that we want patients that are referred to us to try and have everything covered, not have to go to see different people. And so we have expert maternal fetal medicine sonographers, so they're just operating at a obstetric ultrasound level that is different to a general sonographer. They're our technical people doing the imaging. We have maternal fetal medicine specialists like myself that actually are then interpreting the images and counselling the patients and doing procedures. We have midwives that are specially trained in maternal fetal medicine that provide support and ongoing support through the rest of the pregnancy. And of course, our admin staff that kind of pull it all together to make sure that patients are informed of their appointments and when they need to be there. We also have social work, neonatal that come in as needed. But there are our 4 core specialties. So when a patient comes to see us, they will have an ultrasound. They will see a maternal fetal medicine specialist. They will then often have contact with one of our midwives. And as required, that report would be fed back to the referring doctor. And we always make sure the patient also gets a copy. And sometimes it requires a second visit because there's a lot of information in a single visit that often requires, within a short time frame, to get them back, to just go over things. It's a lot to take in. It's we of course work very hard to describe everything in terms that they can understand. It's not a lot of there has to be some medical terms, but we don't want to overload them with information that is really at a medical. It has to be really explained in a way that they can understand it.
It would be a lot for a patient, a woman, to digest, which goes to the next question. As a GP, well, how do I best support my patients who have those complex fetal issues diagnosed in pregnancy?
Yeah, I mean, some parents feel that, why wasn't this picked up? And so we explain very carefully that this is a very specialised area. We would have no expectations of diagnosis or treatment options being provided at a GP level. So the support that we have an expectation on from a general practice is that they know the woman better than we do. They've sometimes cared for these patients for years. And so that kind of level of support that is ongoing once they've left our care is very important. And they can still have great concerns about the outcome of the pregnancy. And so regular ongoing support, touching base with the patient, making sure that all the other things of pregnancy care are attended to, is very important.
What do you see ahead in the future for research in TTTS?
So there's been certainly a lot of change over the last 20 years. We've modified the procedure to make it safer. The likelihood that we'd have to do it again is reduced to less than 1%, whereas previously it was as high as 10%. So there's been remarkable gains already. The future probably is in miniaturization of the equipment. We're a little bit shackled by the ability to project an image from a very, very small tube, because you have to get a lot of information out of that. So fiber optics is constantly improving, and the ability to miniaturize means you're making a smaller hole in the membranes, and so for us, as we get our instruments smaller, we hope that we're reducing the risk of the procedure.
And finally, Glenn, 3 quick questions. And this is to give everyone listening an insight into Glenn when he's not at work. Okay. How do you relax away from work?
I love tinkering. I'm a bit of I kind of like pulling things apart and mucking around with things.
Electrical equipment or anything that moves?
Anything. I kind of grew up, I restored an old kind of car once when I was younger, and now I have an old boat that I like to tinker with.
Goes to my next question, which you may have just answered, is do you have a secret talent?
Actually, I think, it's kind of how my career has evolved into doing kind of fetal therapy within maternal fetal medicine, I think has been based around the fact that even before I did this specialty, I was interested in how things worked and how things can be fixed. So I think that has kind of really helped my career, and I think having good hand-eye coordination, it helps as well. So.
It would. And finally, what words of wisdom would you have for a junior med student just starting out?
I would say, look, don't expect that you're going to know exactly what you want to do from the get-go. You can find your path, and a lot of people want to know where they're going to be very early, and it feels very competitive. But it'll come to you. Your passion will be lit by some of those jobs that you do, and follow that path, and that will lead you to a career that kind of, the old saying, coming to work is actually not like work.
Glenn, thanks so much for your time.
My pleasure.
For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in, and see you next time on sMater.